Welcome, fellow learners. Today's deep dive is into, well, an unexpectedly dense and fascinating world. The taxonomy of surgical procedures. Specifically, we're focusing on the skin and the frame underneath it. We're basically dissecting the language that doctors, hospitals, and payers use to define exactly what happened in the OR.
That's right. And our sources here, they're derived from foundational procedural guidelines, these highly technical documents, used for classifying surgical work.
Right.
Our mission isn't just to list definitions, though. It's really to extract the amazing specificity behind classifying surgery on the integumentary and musculoskeletal systems.
Yeah.
It's about understanding this hierarchy of detail, the logic that defines the time, the risk, the resources involved. It really is the dictionary of surgical workflow.
Okay, let's unpack this then. We're going to start shallow with the skin, figure out how they define how much gets cut, then move down through the layers, debridement, excision, and then explore the framework underneath bone, muscle, joints. We'll highlight everything from precise biopsy techniques to complex reconstructive flaps.
Sounds like a plan.
Let's start literally skin deep. If a clinician suspects something and needs a small tissue sample, even that simple act is broken down, right? Into highly specific codes based on how they get it and how deep they go.
Absolutely. That procedural nuance is critical. And we're looking at codes for procedures performed solely for diagnostic examination for the pathologist to look at.
Just for diagnosis.
Right. The sources detail 3 distinct techniques for a skin biopsy.
So 3 types, defined by depth and technique, I guess.
Exactly. First is the tangential biopsy. Think partial thickness sampling, like a shave, a scoop, or using a curette. Crucially, it just skims the surface. Doesn't penetrate below the dermis.
Okay, shallowest one.
Yep. Second, the punch biopsy. This uses a special tool, like a tiny circular blade, to remove a full-thickness cylinder of skin.
Right, I've seen those. Leaves a little hole, I imagine. Do they bill separately for stitching that up?
Great question. And that highlights a really key bundling rule. The simple closure needed for that small punch defect. It's explicitly included in the service. No separate code.
Okay, got it. Bundled in. Makes sense. And the most invasive one just for diagnosis?
That would be the incisional biopsy. This is a vertical cut, maybe a wedge shape, that goes deep into the subcutaneous space, the fat layer, often done if they suspect something deeper, like paniculitis.
And closure for that one, also included?
Yes, simple closure for the incisional biopsy is also considered part of the package.
Now, here's where the logic sometimes feels a bit backwards, maybe. And it's probably the biggest aha moment for understanding these surgical rules, the bundling. If I'm already having a large, say, cancerous lesion removed, and the surgeon takes a tiny piece just to send to the lab, maybe check the edges, that little sample isn't coded as a separate biopsy, right? Why is that?
You absolutely hit the nail on the head there. That's considered a routine component. Getting tissue for pathology during a planned larger excision or destruction procedure, it's just integral to that main procedure. It's not seen as a distinct standalone diagnostic service in that context. The primary purpose of the main surgery, the removal, dictates the coding. Sampling is just part of ensuring the job's done right.
Okay, that clicks. It defines the procedure based on the main intent. Diagnosis versus removal. Okay, so moving from diagnosis to actual removal excision of a lesion. The way that's categorized seems incredibly strict based on 2 main things.
They really are. For full thickness removal, the procedure code is classified by, number 1, anatomic location.
Location?
Yeah, the body is basically divided up. You have high complexity areas like the face, ears, lips, trickier spots, then moderate complexity like the trunk, arms, legs, and then others like scalp, neck, hands, feet, genitalia, and another group.
And the second factor, this is where people often get confused, I think, size. It's not just the size of the bump or mole itself, is it?
Correct. It's the excise diameter, and this measurement has to be taken before the excision.
Before they cut.
Yes. And critically, it must include the actual diameter of the lesion plus the narrowest margins the surgeon needs to ensure complete removal.
So if a mole is 1 centimeter across, but the surgeon needs, say, 2 millimeters clear margin all around,
then the coded diameter is 1.4 centimeters. That total width dictates the code because it reflects the actual amount of skin removed and, importantly, the size of the defect left behind, which influences the repair needed.
Okay, that clarifies a lot, the total footprint of the removal.
Exactly. Now, we've excised the tissue, but what if the tissue was already damaged, necrotic, infected? That brings us to wound management. specifically debridement.
The debridement, cleaning up dead or infected tissue.
Right. And here, the depth of tissue removal establishes a really strict hierarchy. It's like a surgical geological survey, as you said before.
Yeah. So it's reported based entirely on the deepest layer the surgeon gets down to.
Precisely. The code is determined by the deepest level reached. Subcutaneous tissue, which includes epidermis and dermis, obviously then muscle and/or fascia, or, finally, bone.
So even if they clean out some dead muscle and scrape some infected bone in the same wound, you only report the bone code.
That's right, because the bone debridement code inherently includes removing the overlying tissues to get there. It represents the most complex and resource-intensive part of that particular debridement.
Okay, and surface area matters too, right? What if a patient has, say, 5 separate wounds on their leg, all debrided down to the fascia? Is 5 separate codes?
No, you sum the surface area in that case. You aggregate the total area in square centimeters of all wounds debrided to the same depth.
Oh, okay.
So if you have a 10 square centimeter fascial debridement on the arm and a 15 square centimeter fascial debridement on the leg, you report a total of 25 square centimeter of fascial debridement. You'd use the initial code for the first 20 SQP centimeters and then an add-on code for the additional area over 20.
Wow, that structural thinking is. It's really something. Okay, let's switch gears slightly. Before we talk about repair, let's touch on a diagnostic tool. Fine needle aspiration, FNA. What's the basic difference between FNA and a core needle biopsy? They sound similar.
Good question. It really comes down to what the pathologist needs to see. FNA collects material for cytological examination. They're looking at individual cells, usually smeared on a slide, checking cell structure, looking for abnormal cells.
Go ahead. Individual cells.
Right. A core needle biopsy, though, uses a larger needle to get a solid core of tissue. That's for histopathologic evaluation. It lets the pathologist see the tissue architecture, how the cells are organized together.
So FNA is like looking at the bricks, core biopsy is looking at the wall.
That's a great analogy, yeah. FNA gives you the cell type, core biopsy gives you the tissue structure.
Perfect. Now, the bundling rule for FNA.
Yeah.
This one can feel a bit frustrating. Imaging guidance like ultrasound or CT is almost always needed to make sure the needle hits the target, especially for deep lesions. But you generally can't bill for that guidance separately. Why bake it into the aspiration code?
Yeah, this is a common point of confusion. It's basically a policy decision reflecting the standard of care. Because imaging guidance is so often required for FNAs to be safe and effective, especially non-palpable ones, it's considered an integral component of the aspiration service itself when performed on the same lesion.
Same lesion is the key.
Exactly. Now, if you perform an FNA on one lesion and maybe a core needle biopsy on a different lesion, both using the same imaging guidance session, that's different. That's when you might use a modifier, like modifier 59, to show they were distinct procedures on separate targets, even with the same guidance.
Okay, that distinction is crucial for accurate reporting. Right, moving on to repairing the defects we've created or cleaned up. We have simple, intermediate, and complex closures. When does a simple stitch job become a complex closure?
It becomes complex when the repair requires more than just straightforward layering of tissues. Complex repairs might involve things like extensive undermining, placing retention sutures to reduce tension, or meticulously managing free margins.
Free margins, like edges of things.
Exactly. Areas where precision is critical, like the rim of the ear, the vermilion border of the lip, or the edge of the nostril. Very delicate work. But remember, even a complex repair code only covers the stitching part. It does not include the initial excision of a lesion if one was done. That excision is reported separately.
Okay. But that changes when we move into real reconstructive surgery, doesn't it? Like adjacent tissue transfer, ATT. There, the excision gets swallowed up by the transfer code.
Precisely. That's a fundamental difference. ATT procedures, things like Z-plasty, W-plasty, rotation flaps, advancement flaps, they are reported using specific ATT codes, the 14,000 series codes.
Right.
And because the entire point of that procedure is typically to remove a defect, often a lesion, and then immediately use neighboring tissue to close that defect, the removal of the lesion itself is considered included in the ATT code.
So you don't report, say, an excision code plus the ATT code?
Correct. You must not report them separately in that scenario. The ATT code defines the entire process as one single reconstructive unit, removal and repair combined.
That's a really clear, logical structure when you put it that way.
Okay.
And finally, on the skin, the sources mentioned this amazing-sounding technology, skin cell suspension autograft, SCSA. That 1:80 expansion ratio sounds almost like science fiction.
It really is incredible technology, pushing the boundaries of skin grafting. SCSA involves surgically preparing the wound bed and then topically placing skin cells harvested from the patient.
So not sheets of skin, but actual cells.
Essentially, yes. They microharvest from a donor site, process it to create this concentrated suspension of skin cells, and then spray or apply it onto the large defect. To achieve that massive expansion where maybe 25 square centimeters of harvested skin can cover up to 2,000 square centimeters of burn or wound, you're relying on those concentrated cells to rapidly regenerate and cover the area.
Wow. Resource efficiency maximized.
Absolutely. It's a game changer for large surface area wounds.
Okay, let's pivot now. Deeper structures. The musculoskeletal system. Here, the challenges seem to shift towards managing the internal framework bone, hardware, and tackling deep infections. Starting with fixation. The rules around external hardware, like a halo device for the head or spine, show some unique complexity based on the patient.
Yes, that's a good example. When it comes to external fixation, like the cranial halo, the sources specifically highlight a specialized code. It's for applying the halo in patients with what's called thin skull osteology.
Thin skull, like in kids, or specific conditions.
Exactly. Think very young pediatric patients or individuals with conditions like hydrocephalus or osteogenesis imperfecta, where the skull bones are more fragile. Applying a halo safely in these cases often requires using 6 or more pins instead of the usual 4, placed very carefully. That unique code recognizes the delicate anatomy and the increased surgical complexity involved.
That makes perfect sense.
Yeah.
The complexity isn't just what you're doing, but who you're doing it on.
Okay. And when internal hardware plates, crus needs to come out later, there's a basic distinction based on how deep it is.
Yes, quite straightforward.
Okay.
There's a difference between removing superficial implants like a buried wire, pin, or maybe a small rod that you might almost feel close to the skin surface,
Okay.
versus removing deep implants.
Okay.
These are things like larger screws, plates, intramedullary nails down the center of a bone, or deeper rods that require significant surgical dissection, sometimes through muscle, to access and remove. Different levels of work involved. Got it. Now, one of the most technical areas our sources cover is managing deep infections using these antibiotic-loaded devices. This sounds like customized medicine right there in the OR.
It really is. This involves the surgeon manually preparing drug delivery devices during the surgery. They might mix high-dose antibiotics into bone cement to create beads, or coat a temporary nail or spacer.
And these go right into the infected area.
Yes, placed directly into the site where infection is present or maybe strongly suspected or even just highly anticipated because of the type of surgery. We use specific add-on codes for the insertion and later the removal of these custom antibiotic devices. And the code choice depends purely on the anatomical space they're put into.
And what are those spaces?
The codes differentiate based on 3 locations. Deep subfacial, meaning within the soft tissue layers beneath the fascia. Intramedullary, which is inside the marrow cavity of a bone. Or intra-articular, meaning within the joint capsule itself.
Okay. And there's a major bundling constraint here too, right? If the main surgery already involves putting in a standard spacer, you don't use these special antibiotic device codes. Why not?
That's generally true, because in certain procedures, particularly some joint revisions or reconstructions, placing a temporary standard non-antibiotic spacer is just an expected inherent part of that procedure's typical workflow, maybe while waiting for infection to clear or for a custom implant.
So the main code already accounts for a basic spacer.
Exactly. If the primary procedure code already implies or includes the placement of such a standard device, you wouldn't typically add the separate code for inserting an antibiotic-impregnated one unless it was truly distinct or placed in a different compartment, perhaps. It prevents double counting that aspect of the work.
Right, avoiding duplication.
Mm-hmm.
Okay, finally, for the musculoskeletal section, let's just lock down the basic definitions for fracture treatment. These seem categorized mainly by the surgical approach.
Yeah, this is relatively straightforward. We have 4 main categories. Closed treatment explicitly means the fracture site is not surgically opened. The bones are realigned externally.
Okay.
Open treatment is the opposite. The surgeon makes an incision, exposes the fracture site directly to fix it, usually with hardware.
Makes sense.
Then you have manipulation, which means reducing the fracture using manual force or traction without cutting. This might be part of closed treatment. And finally, percutaneous skeletal fixation.
Percutaneous through the skin.
Exactly. This is neither truly open nor closed. It typically involves placing pins or screws across the fracture site through small skin incisions, often guided by imaging like fluoroscopy. Highly technical, but less invasive than a full open procedure.
Okay, clear categories. Now let's turn our attention to two advanced procedural areas with their own complex rules, the breast and the joints. Starting with the breast, the taxonomy of mastectomy procedures seems critical. The name really determines everything.
It absolutely does. A partial mastectomy is a targeted removal, think lumpectomy, maybe a quadrantectomy or segmentectomy, removing just part of the breast.
Got it. Part versus whole.
Right. Then a simple or complete mastectomy is the total removal of all breast tissue, which might include skin and the nippler-areola complex, but notably, it typically excludes removing the underlying pectoral muscles or the axillary lymph nodes under the arm.
Okay, so simple complete is just the breast tissue itself. If the cancer requires checking or removing those lymph nodes, that immediately bumps up the complexity.
Exactly. That's where radical and modified radical mastectomies come in. These involve the total removal of breast tissue plus dissection and removal of axillary lymph nodes. A classic radical mastectomy also included removing the pectoral muscles, though that's less common now than the modified radical, which usually spares the muscles but still takes the nodes. It reflects a much more extensive surgical field and resource commitment.
Right, much bigger operation. Now, when breast reconstruction is involved, timing seems to be a key factor for coding implant placement. What's the practical difference between immediate and delayed insertion?
It's pretty straightforward. Immediate insertion means the implant or expander is placed on the same day, during the same surgery as the mastectomy. Delayed insertion means it happens on a completely separate day, often weeks or months later in a second operation.
And there's a difference between putting in a tissue expander versus the final implant.
Yes, definitely. A tissue expander is often placed first. It's like a temporary balloon that's gradually filled over time to stretch the skin and create an adequate pocket. Then, in a later surgery, the expander is removed and the permanent breast implant is inserted. Separate codes for placing an expander versus placing the final implant.
Okay.
And the sources are also very clear. Removing an intact implant is coded differently from removing a ruptured implant, which often involves more complex dissection to get all the silicone or saline out.
Nuance upon nuance. Okay, let's wrap up with the joints, specifically the very strict rules governing minimally invasive joint surgery arthroscopy. These rules seem designed to prevent separate billing for steps that are just considered standard exploration.
That's precisely the rationale behind many arthroscopy coding guidelines. For instance, if a surgeon performs a diagnostic scope, just putting the camera in to look around, and then during that same procedure performs a surgical scope actually fixing something, like repairing cartilage or trimming a meniscus in the same joint. The diagnostic part is automatically bundled into the surgical code. You only report the code for the surgical repair that was done. The looking around is just considered part of finding and performing the repair.
Okay, that makes sense. And the rule about removing loose bodies like little chips of bone or cartilage floating in the joint, that seems really peculiar. It's based on size relative to the instrument.
It is incredibly specific, yes. Arthroscopic removal of a loose or foreign body from a joint is generally only separately reportable if that loose body is larger than the internal diameter of the arthroscopic cannula being used for the main part of the procedure.
So if it's too big to just suck out through the existing tube?
Essentially, yes. If the surgeon has to significantly enlarge one of the existing portals or even make a separate incision, specifically just to retrieve that large, loose piece, then it represents additional work and can be reported separately. But if the fragment is small enough to be removed through the standard instruments already in place for the main repair, it's considered incidental to that repair and is bundled.
Wow, okay. Every detail matters.
It really does. And when you step back and look at all this, it's just fascinating how every millimeter of tissue, every layer of muscle, every single piece of hardware is meticulously documented and categorized in this the surgical dictionary. This taxonomy, this whole system, it ensures that the complexity, the skill, the time, the resources required for every single procedure, from a simple skin shave to a multi-stage reconstruction, are accurately represented. It provides a universal logical structure for defining the work.
It really reminds us that behind every simple name for a medical procedure you hear, lumpectomy or knee scope or debridement, there lies this incredibly detailed, precise structure of codified knowledge. The efficiency and, frankly, the safety of a modern healthcare system relies entirely on navigating these complex rules correctly.
Absolutely. So maybe next time you hear about any surgical procedure, think about that. Consider not just what was done, but how many layers of complexity were precisely navigated and cataloged just to accurately report the effort involved. It makes you wonder what other complex, high-stakes, real-world systems, ones that require absolute precision and clarity of description, rely on similar kinds of hidden, hyper-detailed taxonomies to function day to day. Think about, I don't know, naval architecture, or maybe the entire global shipping container system, maybe even software engineering protocols. That depth of hidden infrastructure, the language underneath, it's truly staggering when you start to see it.